Hello, everyone. My name is Dr. Leepika McCauley. I'm a urologist here in the Phoenix Valley, and I'm just really honored to be able to be here today and share with you my presentation on understanding urinary incontinence and pelvic floor prolapse in women. And I think this is a very important topic because there are so many women who just suffer in silence and don't realize that there's options in terms of urinary symptoms and pelvic prolapse. And so I hope today's talk is very informative and gives you hope that yes, there are things that we can do for you. So let's get started. Again, I am Dr. McCauley. I do live in the Valley. I'm in Scottsdale. I'm in private practice with Valley Urologic Associates. And I am a general urologist. However, I have really focused on female urology over the years. I've been in practice for 11 years now. And I really do focus on female pelvic floor dysfunction, prolapse, incontinence, overactive bladder, and we'll try to touch on many of these topics today. I do still see male patients and I love having them in my practice, but to just understand what has become my concentration is female urology. So what is urinary incontinence? Let's first talk about what happens when you are experiencing urinary incontinence. First of all, the word incontinence is referring to bladder leakage, and it's considered the involuntary loss of urine. And so how prevalent is this? 1 in 2 adult women actually have incontinence and experience this, so it's very common. So in the United States, approximately 18 million women. So a lot of women do suffer with these symptoms. So let's talk about the most common types of incontinence or leakage, because there are different reasons for leakage, which is very important to understand because that really needs to be teased out when I'm sitting with my patients so that we can understand what would be the right treatment modality for you. So urge incontinence is the unintended loss of urine that can occur when there's an involuntary contraction of the bladder. So how I describe it to my patients, is that the bladder should just be holding urine and expanding quietly for hours until finally the bladder's full and your brain tells the bladder it's time to go to the bathroom. And if it's socially appropriate, you take yourself to the bathroom and the bladder finishes contracting and you empty your bladder. But if the bladder becomes a little overactive and it starts to contract without your permission, that's when that urgency sets in and the incontinence or the unintended loss of urine occurs because the bladder is a muscle, and as it continues to spasm, it'll just push the urine out without your permission, and that's considered urge incontinence. Whereas stress incontinence is a completely different concept. Stress incontinence is that physical loss of urine during activity. And what happens there is that it's no longer a bladder issue, it's the urethra and the sphincter. And the sphincter is in the middle of the urethra. And for us as women, if the support structures around the urethra just aren't as strong as they used to be, when we cough or jump or sneeze, the urethra tends to move and becomes hypermobile, as we call it. The sphincter opens and then we leak. And that's called stress incontinence. And that again is the physical leakage of urine. And when there's a combination of both, because there's so many women that will experience urge incontinence and stress incontinence, the two together is considered mixed incontinence and makes those patients even more special. So we really have to tailor the therapies correctly so that you can get your best result. So what is the prevalence in terms of urge incontinence versus stress and mixed incontinence? Again, 1 in 2 women have urinary incontinence. Approximately half of those women truly have just pure stress incontinence. And then there's a mixture between the next two in terms of just pure urge incontinence versus mixed incontinence. So just know that this physical leakage of urine is quite common. And again, most women just feel like, oh, that it's normal or that they're supposed to be like that and that there's no treatment options. So really keep that in mind, that there's options and you don't need to be like that. So let's talk about urge urinary incontinence first. Again, it's that sudden urgency and loss of control of urine without your permission, and it can be associated with what we call overactive bladder. which means that you're urinating more than 8 times a day or more than 1 time at night. And that sudden strong urge comes on because the bladder is spasming without your permission. Versus again, stress incontinence is that physical leakage of urine because of the hypermobility of the urethra. And examples of stress incontinence can occur during exercise, a simple cough, sneeze, laugh, or if you're trying to jump or lift a heavy object. So anything physical is considered stress incontinence. So there are two types of stress incontinence if we want to break it down just a little bit further. One is that hypermobility concept, as you see here on the left side of the screen. Again, occurs when the urethra and the sphincter, the bladder neck, are just not adequately supported anymore. And then there is that downward pressure with something physical or some exertion. Now, intrinsic sphincter deficiency is a little bit of a different topic, where the concept is that the inner tissue of the urethra and what we call the mucosa just isn't as thick as it used to be. So sometimes we see that with maturity and going through menopause. And so what happens there is if the inside just isn't as strong as it used to be, it doesn't close up as well. And that can lead to stress incontinence as well. But the cause is due to intrinsic deficiency of the mucosa of the urethra versus physical hypermobility. So they're slightly different because they're treated differently. So who's at risk for developing stress incontinence? So several things. Of course, we see it change with age and menopause. The menopause factor is because the lack of estrogen in our tissues leads to weakening over time. Of course, any of us who have had babies in pregnancy, what we consider pelvic trauma can just weaken the pelvic floor structures. And anything surgical, hysterectomy, any other pelvic surgery, of course, obesity, women who are even more physically active, like some of our, one of my patients was a FedEx worker on the loading dock, so was lifting a lot of heavy things, and that led to her stress incontinence. There is some genetic factors, and there can be some spinal cord injury issues as well, but in general, I think we see it more in women as we get older, and of course in women who have had kids and prior pelvic surgery. Again, what is mixed incontinence? Well, that is the involuntary leakage of urine that can occur for both reasons, so that there's an element of stress incontinence in that patient and urge incontinence. So sometimes it's hard to really tease out which one is happening at which time. And so when I meet with patients, I really try to tease that out so we can approach the most bothersome symptom and treat that appropriately. So now that we've kind of talked about the different types of incontinence and why they occur, let's start talking about some treatment options so that we can understand that we do not have to live like this and that we have options. So what are the barriers to seeking treatment? Less than 50% of women actually discuss their symptoms, and there's a variety of reasons for that. Most still feel embarrassed or ashamed. The vast majority aren't aware that there's even the ability to be helped, and they just think it's a normal part of aging. So given these barriers, I really try my best in terms of reaching out to primary care physicians, our OBGYN colleagues, to just simply bring up the question, ask the question to the patient, because the patient often doesn't say anything. Once you get an answer, then I say, just send them on to me. You don't have to dive deeper into it, and I can guide them through the process to understand that there's treatment options. The other thing I love to do is to reach out to patients, and that's also the purpose of this webinar, is to educate patients directly to know that there are treatment options. And I always encourage my patients to talk to their friends and their family members, because that's the only way we can really spread the word and educate people. So let's talk about some treatment options for urge incontinence and overactive bladder. So non-surgical options would involve things that we consider behavior modification. So lifestyle changes, certain diet changes we can make. Pelvic physical therapy has a big portion to this as well. So there are physical therapists who just focus on pelvic floor and bladder retraining, and they are invaluable to us because they are very passionate about female pelvic floor. They work with our men as well, of course, but this is just such a big problem for females that they're just really focused on female medicine. And then, of course, there's oral medications that we use too. So there is a different oral medications that are primarily targeted to just really help control that bladder and calm that so that the urgency and the incontinence is minimized. Now, there's minimally invasive options. One is Botox, and I do a lot of Botox, whether in the office or as an outpatient, so we have options. And the concept of Botox, again, is if the bladder is spasming without your permission, Botox gets injected directly into the bladder to get it to calm down, which can be very effective. And then there's neuromodulation options, one being this tibial nerve stimulation, which is really neat because it's a non-invasive procedure where we can stimulate the tibial nerve near the ankle with what looks like an acupuncture needle. We do it here in the office. And what this treatment is doing is sending signals up to the nerve to the bladder to calm the bladder. So a really good option. And the surgical option, which I do a lot of as well, is the implantation of a sacral nerve stimulator. So the sacral nerve is the nerve that actually controls the bladder and bladder function. And I can implant a lead and a stimulator similar to like a pacemaker, but it's our own little pacemaker for the bladder. And when that's implanted, it modulates the nerve to the bladder to help calm that urgency and that urge incontinence. So some really good options for treating urge incontinence between conservative and even some minimally invasive surgical procedures. So let's go on and talk about treatment options for stress incontinence. Again, that physical leakage of urine. And again, there's non-surgical options. Again, our pelvic floor physical therapists are just invaluable at this step to really teach you how to strengthen the pelvic floor correctly, more than just me saying, oh, go home and do a Kegel exercise, because that's not quite right. The pelvic floor is very complicated in all the different muscles that play into bladder control. So I think the pelvic therapists are really helpful in terms of figuring out how to get to teach you the correct way to strengthen the pelvic floor. And then there is something called a pessary, which is a device that can be inserted into the vagina to actually give that support to the urethra once it's inserted into the vagina to help prevent the leakage. And that's an option for some of our women if you want to wear that during physical exercise or if you're going to go out and about and you need that support, and then you can take it off when you get home. Now, in minimally invasive options are a couple things here. One is considered an injectable bulking agent, and that's really for our women who have that intrinsic sphincter deficiency, where on the inside, if we're trying to close up that urethra a little bit better, the bulking agent, which is similar to like collagen for the lips to help bulk up the lips, it's an agent that we can put on the inside of the urethra to get that inside to close up a little bit better and help with that leakage. The other kind of minimally invasive surgical procedure is what we call the mid-urethral sling. And that concept there is for that hypermobile urethra. Again, if the urethra is moving and the sphincter opens and we leak, the sling goes underneath the urethra to support the urethra. So then when we cough or sneeze, it shouldn't move and we shouldn't leak. Other surgical options that are just not used as much anymore because they are more invasive and don't seem to have the long-term longevity of success that we've seen over time are things called bladder neck suspensions or even a Birch-Kulpo suspension. Again, really not done as much anymore because they are more invasive with not as good outcomes. So hopefully this helps show you that, again, there's multiple treatment options for stress urinary incontinence. And then again, just reiterating, mixed incontinence may involve treatment options for both. And so what I do for women here is, first, I really try to tease out which symptom might be more prominent or more bothersome and focus on that first. So if it is the stress incontinence that's more bothersome, treat the stress incontinence and see how the urge incontinence plays out. And if it's still present, then it is not unusual in these women to have to involve kind of several different treatment modalities to treat the symptoms appropriately such that you feel like you're getting relief. So who can treat incontinence? Well, there are general primary care doctors that do understand incontinence and can prescribe the medical treatment options and even get you into pelvic therapy if they're thinking about it. A urologist, like someone as myself, this is what we do. We're very passionate about the urinary system. And so we can definitely help guide you in terms of the right treatment modality for male and female urinary issues. And then there is a urogynecologist that can also help us, who they are gynecologists by training, but then have done some further training in the urologic section too, so that they can help you with bladder and pelvic floor issues. So there's definitely options in terms of who to go to for treatment modalities. So what can you do as patients to learn more about this? Obviously, talk to your physician, bring up the concept if you can. And then if you're looking for a physician that can specialize in the treatment of incontinence, this website, chooseyou.com, can also help guide you. And just know that your physician should really be able to go through all the treatment options with you and help guide you through what might be an appropriate treatment option specialized for you. Also be aware of any risks and benefits and really feel comfortable that you understand what kind of treatment that you're about to undergo. So now we'll switch gears a little bit and start the discussion of a pelvic organ prolapse, which conceptually is completely different from urinary incontinence. So what we'll discuss is, again, what is pelvic organ prolapse? What are some of the common causes and symptoms, the different types of prolapse, and then the treatment options. So pelvic organ prolapse, often referred to as POP, can occur again when the muscles and the ligaments of the pelvic floor just aren't as strong as they used to be and have become stretched out over time, whether that's because of childbirth, menopause, those kinds of things. And that's what can lead to different organs prolapsing through the vagina. And those organs could be the bladder, it could be the rectum, or even the uterus. So we'll go through and tease out what the different prolapse types are. So how common is it? Well, up to 50% of women who have given childbirth can actually suffer from some degree of pelvic organ prolapse, and more than 3 million women in the United States do experience symptoms. So pelvic organ prolapse truly is more common than you think, and that, again, you're not alone, and that if you are one of the women that are experiencing pelvic organ prolapse, is to understand that, again, there's treatment options and you don't just have to live with it. So let's first dive into what are some of the potential causes and symptoms of pelvic organ prolapse. Again, similar to what we've already been discussing, pregnancy, childbirth, aging and menopause, where the ligaments and the tissues just aren't as strong as they used to be. Prior surgery and even obesity will put just more pressure on the pelvic floor. There can be some genetic factors, women who are chronically constipated and straining, that can also lead to more pressure into the pelvic floor. And then, of course, our smokers, the tissue integrity is often just thinner, and that can often lead to pelvic organ prolapse. And again, our women that might do a lot of heavy lifting, that can be a risk factor for them as well. So what are some of the symptoms that are associated with pelvic organ prolapse? So women often come in saying that they feel this kind of pelvic discomfort or pressure. It does worsen with physical activity or prolonged standing. And oftentimes women will also come in and say that there's diminished bowel or bladder control, sometimes even painful intercourse. I have had women too who, because of the prolapse, they're really just complaining of low back pain. So that can be associated as well. But the most common thing is women will say when they come into me is that they feel like there's something in the vagina, that it's almost like a ball structure, it's sticking out and they can feel it. And that's what leads to symptomatic pelvic organ prolapse. So let's talk about the different types of pelvic organ prolapse, because anything can really be protruding through the vagina, and it's important to figure out which organ it is, because then that will really help tailor the correct surgical approach to fix this if we're going to do something surgical. So the terms that you'll hear is, first of all, a cystocele, which happens to be the most common. And that is when the bladder drops and herniates through the vaginal opening. And that's when you feel that little ball structure at the opening of the vagina. So if you see the picture on the left side, what that's demonstrating is the bladder portion is protruding onto the vaginal wall. And then when you do an exam on a woman, that's when you can see it just kind of coming down and is at the opening of the vagina. The other component that can occur, especially in women who have already had a hysterectomy, is the vaginal vault itself will prolapse. And how I describe this in the office to my patients is, if you can picture the vagina as a sock, and if you put your hand in that sock and think that the seam of the sock at the top is the top of the vagina, the front is the bladder, and the back is the rectum, and then start taking that sock and start turning it inside out, that's prolapse. That's our insides coming down. So if it's top of the sock, that's where the uterus is. That's what we also call as vaginal vault prolapse or uterine prolapse, when the whole top part is just caving in. Or it could be a little bladder, which is the cystocele, or it could be a little bit of rectum, which is the rectocele, and we'll go over that as well. So the picture on the right side here is showing the top of the vaginal vault is what's coming down, and women will still feel that ball-like structure in the opening of the vagina. Again, the rectocele, as we were talking about, is when the rectum from the backside is protruding through the vaginal wall. And the women who struggle with a chronic constipation and are straining will often develop a rectocele. So that's the herniation of the rectum. And even sometimes small intestine and bowel can herniate into the vaginal wall, and that's called an enterocele. And it is more common in women who have already had a hysterectomy, because now just the top contents, all the intestines, are falling down to the top of the unsupported vagina, the unsupported vaginal vault, or that sock, as we should say, is now kind of closing in on itself. So what are the treatment options for pelvic organ prolapse? And what do you need to know about pelvic organ prolapse treatment? Well, the first thing to know, and I say this to all my women, is that this is not life or death. This is all quality of life stuff. So even if I examine a patient and can tell there is an element of prolapse, if you are clinically asymptomatic and you don't feel a bulge and you're not bothered and things are okay, then it is absolutely appropriate to be conservative and not treat that, because it's clinically not causing any symptoms. But depending on the severity of what you're experiencing, or if your prolapse is simply hanging out of the vagina, well, you don't want to be like that, then yes, there are treatment options, and we'll go over some of these. We'll go over the gamut of what we can undergo. Dietary changes and weight loss can be huge in terms of reducing that pressure onto the pelvic floor. Again, our pelvic physical therapists are still part of this treatment modality, where they can really help, train you and treat you appropriately on how to strengthen the pelvic floor and make you feel better about that prolapse symptom. A pessary is definitely something that's an option, especially for patients who do not want to undergo surgery or who are not surgical candidates. And I describe the pessary as almost like a little diaphragm structure. What it does is it can go into the vagina and help support all the vaginal structures, such that you can go about your activities and not have to worry about that prolapse sensation. But the pessary can be removed, taken in and out, so you can really be flexible in terms of when you want to wear it. So when is surgery the right option? And that's always a good question to think about. Well, first of all, the goal of surgery, especially in my mind, is to recreate the normal anatomy of the vagina and to really restore proper function. There are certain procedures that will change the anatomy of the vagina, and if a woman is still, sexually active, we really want to take this into consideration and restore the normal anatomy. So your first step would be, well, make sure you can consult someone who does specialize in not only female pelvic medicine, but reconstruction modalities. And that we should undergo consideration of your anatomy, your overall health, what prior surgeries you've had, and what your risk factors might be. And then really understand the surgeon's experience and how comfortable they are with the particular procedures. So let's talk about the different surgical options and how we can undergo repair of pelvic prolapse. So the first one is the use of a synthetic or a biologic graft. And the reason why these grafts were designed is because we know that the tissues of the pelvic floor have become so weak, that is why things are falling. And so if you don't use some kind of graft to give that area strength, and if you just try to put a few stitches in there, oftentimes things will still fall down. So that is the concept behind using some kind of graft to really support the tissues of a weakened area. Now, a specific procedure called a sacrocolpopexy or a sacrohysteropexy is the concept that through a laparoscopic robotic approach, what we can do is enter into the abdominal cavity and use a graft that we can really attach to that to the vaginal vault and really help lift everything up. Again, conceptually, it's like seeing that sock that's turned inside out, picking that sock up from the inside, and then being able to anchor it to a ligament on the tailbone of the sacrum to give it that strength so things don't fall back down. Something that's very common and very well tolerated because it is the robotic approach. It's minimally invasive and women just are tolerating it very well. So it is an option, even though it is a surgical procedure. And then there is something called a native tissue repair that if the prolapse is on the milder side and the tissues don't seem overly thin, then if you can go in and just do a suture repair where you bring the native tissues back together, that can also give women some relief of their prolapse symptoms. So just understand that there's different surgical approaches, all in the aim of correcting pelvic organ prolapse, and just understand with your specialist the different options and the potential complications and things to understand that are going to be part of your postoperative care as well. So what can you expect after surgery? So my goal for patients after surgeries like this is to understand that that bulge will be gone and that you can resume normal activities and feel like you don't have to worry about that pressure, that bulge, or even that pain that could be coming from the prolapse. But every patient's recovery is quite different. And just to really understand that as you're going through the recovery process, if it varies from your friend that you've talked to or other people that have gone through this, that can be very normal. And as we give it time, I often sound like a broken record, but at least the first 3 months to really understand how your body's going to settle out is an appropriate time to wait in terms of the healing process. So what are your next steps if you really are thinking that you could be that person who does have pelvic organ prolapse? What can you do? Well, first of all, again, learn about the condition, bring it up to your physician and ask questions. And then if you want to find a physician who does specialize in this treatment modality that could be near you, would be back to that website, chooseyou.com, to help you find some of those specialists. And again, make sure you feel like you're getting an understanding of all your treatment options and that any of your questions or concerns are adequately answered by the provider that you decide to seek consultation. So again, these are the references for this presentation that was put together. I am very thankful again to be able to have this opportunity, to be able to reach out and touch base with patients in a personal manner, but being able to do it at flexible time frames. You don't have to come in, and this gives you the ability to hopefully learn that there are treatment options. If you have any questions or ever want to come in for a consultation, now you know who I am and where I'm located, and I would be more than happy to help guide you with this process. So thank you again, and I appreciate it so much.